Hi, I'm Danielle Matias here at Caring Medical Florida with Dr. Fernanda Paulsen from Back in Motion. Dr. Fernanda is a pelvic floor physical therapist, and we're going to talk all about pelvic floor today. Dr. Fernanda, what type of pelvic floor patients do you typically see?
I see a very wide range of patients. I see patients that have urinary incontinence, constipation, pain with intercourse. We have males that have also pain with ejaculation. We see pre- and postpartum women. We see patients that have just sacroiliac dysfunction and things like that.
That is a wide range.
Yeah.
Do you find that you typically see patients like right when the injury starts, or you see more kind of like chronic pain, chronic symptom patients?
Unfortunately, by the time they know that pelvic floor therapy is a thing, they're more into a chronic stage. We're trying to change that to get those patients when they first start to have symptoms. But right now, my caseload is mainly chronic patients.
That's mine too.
Yeah.
You know, people that, and I would say the pelvic floor patients that I see are mostly women, but I see men too, of course. And it's women that maybe have ignored it too, you know, like we're busy, we got other things to do,
Yes.
like it's kind of on the back burner, or they don't know what to do,
Yes.
you know, and they don't know kind of who to see, you know, like what therapies they need, kind of where to go, which is hard.
Yeah, it's really hard. A lot of women think that leaking is something that they just have to deal with.
Right, it's normal.
Exactly. They've been told by different medical professions that it's part of aging, it's part of having kids, or maybe it's just hormonal change because we know that declining estrogen can cause that too. And that's not the case. Even though it's very common, it's not normal. And once they get to me, they can get the help they need. But by the time they get here, they definitely been to the loops of the medical system, so they're sometimes discouraged and they don't know that they can have that kind of help either.
I love what you just said. You said just because it's common doesn't mean it's normal, right?
Exactly.
No, I think that's true, because I think that specifically like women with like urinary incontinence, like, oh, I know so many people that this happens to, you know, or like my family, like they have that too, so this is just it, which is right. That's not normal.
No, it's not.
You said something to me one time, I think like the first time I met you, it was specifically about women post-baby. Yes. And you were like, listen, like when people have ACL surgery or, you know, knee surgery, they go to physical therapy. Like this is just what we do, right? Yeah. That's normal and that's part of that. Why after childbirth do we not do pelvic floor PT? Like why is that not a thing? Why is that not like this kind of standardized? And I had never thought about it that way, but it was like this light bulb that went off. I was like, yes, that's a big ordeal too. Like we need to keep ourselves healthy in that regard, or any kind of pelvic trauma, right?
Yes,
you know,
exactly.
male or female alike.
Yeah.
That should be part of care, in my opinion.
If you think about just the word trauma on itself, childbirth, it's not that trauma means that is a bad thing,
right?
But it put trauma into those ligaments, into the muscles. So why these women are not being educated that they can get rehab, and if you have a C-section, they are cutting through all the abdominal muscles, and that on its own can make the pelvic floor weak. So we're trying to change the culture by talking to OBGYNs, talking to other medical professions to see if we can change that and become more normalized, that the woman will get the help they need after they have a kid, for example.
After I had my twins like 3.5 years ago, at the time I had like rectus diastasis. So like not technically a pelvic floor thing, but it's all related. And I remember like asking for physical therapy. And I remember calling a physical therapy office and they were like, we don't know what that is. Yes. I was like, I don't understand. Like what is happening? You know, I'm just trying to like get some help here. So I do think there's this huge lack of education. And I see chronic patients too, right?
Yeah.
You know, patients that have had, maybe it's childbirth, maybe they had a bad fall, maybe they had a car accident, whatever. And maybe it started out as like a sacroiliac ligament thing. You know, kind of in my world, my world's more ligaments. Maybe it started out as a ligament sprain or a pubic injury. Yeah. And then we all know, like, as these injuries go on, it's not that they all of a sudden miraculously get better. Yes. Right? I mean, that'd be fantastic. Miracles happen. But it's usually like, okay, this becomes more chronic, or I can deal with it and my pain like gets better, but it's only because I'm not doing the things that I want to do. You know, like you can control your pain probably to some extent if you're not skiing, if you're not, you know, riding your bike or doing things, which, I mean, that's not the answer either.
Yeah, I like that you said about the diastasis recti. I'm going to get the motto here. Because the pelvic floor is actually part of your core. So your core, if you think about it, the deep transverse abdomen is the deeper layer of the core here. It wraps around the torso and it connects with your back muscles here with the multifidus. And the pelvic floor is the bottom of the core and the diaphragm being the top. So it really forms like a canister. Any imbalance that you have in any of those systems could affect the pelvic floor. Even though when we are pregnant and we have that separation, we might think, oh, that's not going to affect your pelvic floor, but it will, because it's going to change the length-tension relationship that we need for the muscles to function, and that on its own can have an effect on how the pelvic floor muscles are going to respond to that. So part of the PT that we do, we don't just focus on the pelvic floor muscle itself. We have to see what is going around, including the strength of the muscles around the hip girdle, the core, how are they breathing, posture, because all of those things can actually affect the way that the pelvic floor is going to respond.
You have more of like a kind of like Pilates, yoga, type physical therapy style that you do. I would imagine that's very helpful for all those deep abdominal muscles, for all that strength, for the core. Yeah,
100%. I have a master's degree in the science of yoga therapy, so I do a lot of down regulation practices too, together with breathing, because the way we breathe can change our intra-abdominal pressure. So if you don't breathe correctly, we can put more pressure into the pelvic floor itself. But also we know that a lot of women that has pelvic floor issues are coming from a trauma perspective, whether if they have a personal trauma to them, trauma with birth. So there's a lot of psychological components that once they come to me, they're on that sympathetic drive. So just by breathing correctly, we can begin to down-regulate the nervous system and be able to do the things that we have to do. Because sometimes they don't even want to do internal work. So they're so scared. So first we have to bring them down, quiet them a little bit, then we can do and go deeper into the things that we want to achieve with them.
I learn so much every time I talk to you, but I think that you're making a lot of good points, because there's like you could think of it as like, okay, just, I say in quotations, like pelvic floor pain or dysfunction, the way that it also affects your autonomic nervous system, like your psychological health, like there's so many just other layers to it. And I would say like in most of the, if not all actually, of all the pelvic floor cases that I see, there's such a psychological component, because they've had this pain for chronic pain in general, right? Like you're not going to be yourself. They've had so much pain, so much dysfunction, it's getting worse. They're losing their quality of life. They maybe don't, and they don't know what to do. You know what I mean? And it's maybe they have been told like, oh, this is normal, or they just are under their own assumption of it. It just really kind of wreaks havoc on a lot, and it wreaks havoc on not just the patient itself, but like relationships, right? With spouse, or just in general. And it's such like I would say a passion of mine, because you just like, if you could just get rid of people's pelvic floor pain, help them and those that are suffering, like the way that you could just change people's life is just incredible.
Yeah, 100%. I agree with that. And I think the beauty of physical therapy, it's because we're very goal-oriented. So the care is very personalized, because we have patients that they're only trying to pick up their baby from the ground. But we treat high-end athletes, because we know that females that are in younger age can also develop pelvic floor issues. So it really depends on what they're trying to go back to. The treatment is not like one size fits all. So we really have to customize and make it so the patient feels seen and heard, especially when a sensitive topic like that comes, right? So we try to like listen to them and then target to what they are trying to go back to do.
No, I agree. And I think like with your practice obviously being more like muscle driven, et cetera, ours is more like ligament driven, right? So, but they work together, they're like part 100%. Of the same sphere. So like examples of patients that I would see are, patients that, mostly like sacroiliac dysfunction, that has that's their main issue, and that's what's causing all of these, muscles of the pelvic floor. Actually, I think I have a graphic of it, muscles to spasm and tighten, and they get a lot of like, again, women, vaginal tightness and so forth related to it. Or, pubic symphysis injury, combination of both, where then if your sacroiliacs are loose and your pubis, you have this like seesaw and all these muscles, are just trying to like fight for their position. If we just think about the pelvic floor, like very similar to your model. So this is the pubis here, right in the front. And then as we kind of loop around back towards the sacrum, these are the sacroiliac joints there. Now, yeah, there's a lot of ligaments, right, that hold all these together. If patients have loose ligaments, that's what we want to tighten. But the balance is too, is that all of these muscles here that you have on your model here as well, they're getting a lot of their like kind of proprioception input from like the stability of all of it.
Yes.
And so patients that have, you know, in our world, we talk about instability from ligaments or instability from just poor muscle activation.
Yes.
In patients that I see, some of them have tried some physical therapy.
Yes.
You know, whether it's specific to pelvic floor, maybe it was more general. And I find that, hey, if there's a muscle weakness problem here, if there's a muscle issue here, probably I would never see them.
Yeah.
You know what I mean? Like they would go to a good physical therapist like yourself, they'd get fixed. But if there's a ligament component and I stabilize their joints, treat their ligaments, if they go back to physical therapy, which they might have to, they just excel. Like they just do so well because the combination has kind of rebuilt this chronic degenerated area of their pelvis and they flourish. It's awesome.
Yeah, I agree with you. Sometimes on my end too, we have patients that we do everything we can to help them, right? But we know that they have that underlying connective tissue disorder, for example.
Yeah.
So then we can work on posture, we can work on habits, we can work on strengthening the muscles. But if we can regain stability on the joints, then I have to refer them back to you because it gets to a certain point that, for example, I have patients that we will manipulate the sacroiliac joint and we put him back in place. And then we go through the series of exercise. By the end of the session, she's out again. So when it's a pattern that happens over and over again, and I can't gain stability just from working on the muscles, then that's when I would say, listen, I think it's important for you to try something different so we can gain some stability on the ligaments itself. So now your muscles can have that chance to create a good length-tension relationship, and then you can come back to me and you can retrain those muscles again. So I think it's like sometimes we do hit a wall, right, as a practitioner, and we have to be honest with the tools that we have and refer them to the source because at the end of the day, we want them to get better. So if I think that they should go see you, I 100% will refer them to you.
Well, and I think, like, again, you're making a good point on even just collaboration. Like, I feel like, I mean, you could, again, make this case for any other joint in the body, but I feel like for pelvic floor, like a good collaboration team, like people that communicate to each other, that understand, I think is really important because I also think that can be lacking for certain patients, which is then, again, just adds to the frustration of everything that's going on.
Yes, I agree.
What are some key differences in your field, aside from the obvious, on like male versus female pelvic floor disorders? Or do they end up being very, very similar?
In a way, they can be very similar, but they come from different diagnosis. For example, women, you see more urinary incontinence due to child's birth, due to age, things like that. I see a lot of male when they come prostatectomy, for example, because it's a very risky surgery, and a lot of them ended up having either erectile dysfunction or urinary incontinence or fecal incontinence. So most of my caseload right now, from male patients' perspective, is post prostatectomy. Men also have constipation, so that's another thing that we can treat. And pain with intercourse, it's a big one too, maybe post-ejaculation pain and things like that. So in a way, they have the same muscles, but the treatment is different, of course, because they're a male patient.
Sacroiliac stuff I see much more commonly in women. We just tend to be a little bit more hypermobile in general compared to men. And I think would you say like men are more prone to like nerve irritations causing pelvic floor? Or maybe that's
Yes, I see a lot of patients with pudendal neuralgia, for example, because they don't have good hip mobility. So they don't have so tight muscles to also press into those nerves. So we definitely see patients that have mainly pudendal neuralgia, or they can have something going on with S2, S4 nerve termination, and that's going to create more pain on the scrotum or on the penis itself. That is related to nerve.
When you said hip mobility, that reminded me too. Like I would say, like kind of like a stiffer hip, right? You know, like it doesn't move as well, like all that kind of like muscle fascial tension.
It also could come from instability, right? We don't think that, but if they have some sort of instability, those muscles are going to naturally want to guard.
Yes.
And
yes.
that creates tension, and that tension puts pressure in the nerve. So it's not that men don't have instability, they can have that too. But on my clinic experiences, it's usually the opposite. They're more like the stiff kind of population.
Especially with all these muscles here in the pelvic floor, right? Like there's a long list of reasons why those could be tight. If this pubis, if any of these sacroiliacs, which are kind of dipped back in there, are loose, these muscles are like, I mean, they're trying to give you the stability you don't have. So they are spasm, they are tight. And people might feel like, no, I don't feel loose. Like I feel tight. And you're like, okay, well, really, like, what's going on? You know, why is the tightness there? Is there an underlying injury to soft tissue there?
Yes.
Unfortunately, we're just seeing all of these people that have just been suffering for so long. You know, like to be honest, I don't know if I've ever seen an acute like pelvic floor injury. You know what I mean? In this office, and you just wonder, like, gosh, if we could, you know, just see these people like
a little bit sooner.
Yeah, you know what I mean? Like these people that have pain for years, like decades, you know, like it's these balls of yarn that we just have to unravel. And obviously, like the longer it is, it's doable, but you know, it's just more work. So
I agree with you. By the time they come to see us, they have been misheard, missing, and they don't have that support either from the medical field, or they believe they can't change it anymore because they try so many different things. Yeah. And so part of the work is mainly patient education. So we have to like build their confidence, and that's it. That takes time too, and it's unfortunately by the time they get to us, they are discouraged, and our job is to like motivate them again first, and then we can go ahead and treat them.
Absolutely. And I think part of that too is, okay, what's your diagnosis? Like, what are we working with here? You can say, okay, yeah, you have urinary incontinence. You're like, okay, great, that's my diagnosis. What does that mean? Why do I have that? What is going on here? Is it a hormonal thing, right? Exactly. Is it like a structural thing? What's going on? Or pudendal neuralgia, right? Yes. Okay, I have pudendal neuralgia. I want to have an appropriate treatment plan. Like, why is this happening? You know, and I think like digging deeper into that and what's actually going on, why is this developing, is just so important.
Yes, I agree with you. And then from a physical therapy perspective, that's why we treat the whole body, right? Yeah. We're not just zooming in the pelvic floor. We have to look at the hips. We have to look at the core. We have to look at posture. We have to look at everything around it, because sometimes they do have urinary incontinence, but it's not coming from the pelvic floor muscle itself. And you can do things to change that. For example, with prolapse. Sometimes they have prolapse because they have childbirth and then there is a sagging there. But sometimes they do have a ligaments disorder, and I can't really help them as much as you could probably take some of those things with POP and things like that, right? Yeah. So we have to see what's causing that.
So recently I had 2 male pelvic floor cases, more like nerve burning type, like nerve related pain in the pelvic floor. And we do motion x-rays of the pelvis and the low back. And I was like, well, they're not really that bad. Like, there's not really a lot of instability here, not a lot of ligament things. But these people, not to pick on them, they're sitting like shrimps. Oh, yeah. You know what I mean? Yeah. They're just like hunched over all this stuff. And I'm like, okay, we got to dig deep into here. Maybe this isn't actually a ligament issue. We got to like actually send you out for, you can't like just, be a shrimp all the time. They just think about all the nerve tension, right?
Yes.
Like throughout that's going on. Yeah.
That's why posture sometimes is all they need. Then you think,
but nobody wants to hear that, right? Nobody wants to hear that though. They're like, I have to work on my posture, but it's true.
And sometimes it's just breathing. If you think about the breath, how you can change the way you breathe, it can affect the way the pelvic floor function. For example, if you have a decreased thoracic mobility, for example, and you're trying to take the inhale, but your thoracic doesn't move, now you're going to have to push your internal organs even further to create space for that breath to come in. Sometimes just by changing a little things and manipulating the thoracic, so now they can breathe better. Now they're sending less pressure towards the pelvic floor. Sometimes it's like it's not even related to the pelvic floor at all. So we have to be able to see and pick and choose what are we going to do with each patient that we see.
Yeah, and it has to be tailored, because I think if you have this new patient and you're like, okay, like, we're, thoracic, pelvic floor, they're like, okay, like it's like overwhelming, right? Like, okay, no, what does this patient need? Like, let's keep this. Simpler things are not always easy, right? But simpler things are easier to be compliant with. So, I agree. I agree. With care being so individualized, this might be a hard question I'm going to ask you, but like, what does a typical like pelvic floor physical therapy regimen, like look like? Do you see people multiple times a week? What is it? Yeah.
Nobody likes to hear that, but it depends, right?
Yeah.
When we're talking about muscle itself, it takes at least 6 to 12 weeks to see change in strength.
Okay.
So if a patient comes to me and they have like zero pelvic floor activation, they try to do a Kegel, there is nothing there, then I know that patient is going to need at least 10 to 12 weeks to be able to regenerate and gain strength on those muscles. Some patients respond right away because some patients, all they need is to being told, don't drink a lot of coffee and drink more water and you're going to decrease urgency.
Okay, I don't want to hear that.
Exactly. But then sometimes it's just a lifestyle change that they need and they don't want to be compliant to it because they do like to drink coffee throughout the day and they don't want to drink water. Therefore, they're going to have that urge. It really depends. But usually we're talking about 6 to 12 weeks.
Okay.
I like to start them twice a week for the first 3 weeks so they get with the program.
Sure, like in a routine.
Exactly. After that, I can let them go loose as long as they're going to be compliant with their exercise program and the things that we're asking them to do. So it really depends. Some patients are on it and we'll tell them do this and they're going to do it.
Yeah.
Some patients we know they don't. So those patients I try to see them twice a week because I know they're going to go home and they're not going to listen and they're not going to do anything. So then I'll keep them a little longer twice a week. But it really it depends.
Yeah, you're exactly right. Like in our world, the more unstable somebody is, right? The looser their pelvis is, the looser their sacroiliacs are, it's going to take longer, right? You know what I mean? Like that's why, again, like if we can just catch these people when it's so much more acute, it's so much less care that they need. The more unstable they are, the more Prolo they need. And if somebody is like crazy loose, like several millimeters of extra movement, like in their SI joints, we talk about Prolo being every 4 to 6 weeks. I won't let them go 6 weeks. I'll say, you know what, you're someone that maybe I need to see you every 3 just because I don't want that much time in between treatments for this to just kind of like unravel or loosen again. Like we got to be strict about it. Or I put them in a brace, which I know a lot of PT people maybe don't like, but I'll put them like in a sacroiliac brace or something temporarily just to kind of help hold things together while it's healing.
Yeah, it's not that we don't like braces. Well, I think there's a place for it.
Yes, I agree.
Sometimes, for example, if it's a woman that just have a kid, we want to stabilize that right away.
Yeah.
Right? We want it because it's going to take time for that patient to be able to go through rehab.
Sure.
And we don't want them to suffer. But when we brace, the muscles are not doing what they're supposed to do. So at some point, they're going to have to let go of that brace and strengthen the muscles and so on and so forth. And also with the sequencing with Prolo, I want to mention that because I have a patient that did 3 sessions. And she's like, I'm not seeing any results here. It's like, well, maybe you just need that one more. And it was like bingo. On the 4th one, she saw the result. And with the PT is the same. Sometimes we have to be a little bit patient with the process of therapy because we might not see the results that we want to on 1 or 2 or 3 sessions, right? So don't get discouraged because we have the tools, both me and you, to help the patients, and they have to it's a little bit of a faith loop here. Yeah. But we know that we can, and we've seen this in our profession. Like sometimes it just takes a little bit longer, so don't get discouraged. I think it's the message.
No, I think that's true because like if I was going to the gym, like I would not expect I'm going to go to the gym twice and now I'm going to be super strong. Like I would love that. Yes. I mean that sounds great, but that's not how it's going to be, And some people, like if their muscles are so like poorly activated, or in someone that is like severely unstable, it's like, okay, what we have to do is we have to work on getting these muscles like starting to fire. Just because they start to fire or just because your ligaments start to stabilize a little bit doesn't mean that you're actually going to feel better until we can get them firing in a more normal range or get your instability from severe like towards mild. Yes. Now, every step along the way, that's important, but it might not feel more stable until you're down to like, 1 millimeter of instability versus like the 5 that you started out with, right? So I do think that's important, like patient education for that too. Like this is what we need to do. And we're a team, right? Yes. Like you and me, patient, myself, and we're adding physical therapy, we're adding whatever. Like we're all a team that has to work together and all be on the same page.
Yeah, I agree 100%. Yeah.